What to expect at your first gynecology visit.
Let's talk about consensual pelvic exams.
10 things your gynecologist wants you to know.
Do pelvic exams make you uncomfortable? I'm Dr. Leslie, and I'm here to help.
Well, what's the big deal? It's just a vagina.
As a doctor, one would like to think that putting a woman in this situation is not going to turn her into some kind of strumpet.
All right, so hi, my name is Cornelia Smith, and tonight I will be presenting Practice Makes Patients, Diagnosing the Design of the Pelvic Exam. A small note about content. This presentation includes depictions of genitalia, as well as non-graphic mentions of sexual abuse, racist violence, and self-harm. In 2015, 52 million pelvic exams were performed in the United States. In 2017, researchers asked a sample of adult women in the US between the ages of 21 to 65 the question, do you know why the pelvic examination is performed? Nearly 1/2 of respondents did not. If you were to ask me that question 9 months ago, I probably wouldn't either, which is saying a lot because at 25, my history with pelvic exams is more extensive than most. We go way back. I was 16 when I had my first pelvic exam. It was late June of 2013, the summer between my sophomore and junior year of high school. This was not a routine visit. Rather, I was there because an MRI I had received a few days prior revealed that the excruciating back pain I'd been experiencing for the last several months was not a disc or a muscle problem, but in fact a football-sized tumor attached to my left ovary. I'm not going to go into the details that followed because it's not relevant to this presentation, but I will say, thankfully, everything turned out okay. Why I do mention this experience is because that first pelvic exam set in motion the many I've had since. That first exam is still strongly etched in my memory almost a decade later. What I remember most wasn't the pain. It was the lack of control I had over my body. I remember not knowing what was going on, not being told what to expect or how to prepare. I remember worrying about not having shaved down there, not knowing what was even down there. It would be a couple years before I took a mirror and checked for myself. I remember undressing from the waist down quickly, worried the doctor or nurse would come in before I could swaddle my lower half in a white sheet. I remember feeling embarrassed. I remember being asked what exam I would prefer, and not knowing there were options, not knowing what the options entailed. I remember feeling like such a problem in so many ways except for the problem that brought me there in the first place. I wish someone would have walked me through what to expect. I wish I hadn't been kept in the dark about my body, what tools are involved, what the doctor saw. I wish someone had asked how I was feeling about everything. I wish I knew how to advocate for myself. My experience is not unique. A lack of knowledge and what to expect for a pelvic exam is a large-scale, systemic issue that has harmful consequences. And it is a problem for two main reasons. One, lack of bodily autonomy and agency, and two, the opportunity to be taken advantage of by providers. In February, I spoke with Crystal, a 26-year-old marketing manager based in Tennessee. I found her on TikTok. As part of my research this past year, I looked into TikTok as a valuable resource-sharing platform for gynecologic information and came upon this video of Crystal that Crystal posted last November. Superimposed over an old photo of Crystal standing inside profile is text that reads, "When everyone thought I was pregnant, but I had a 68-pound ovarian cyst that doctors wrote off as just fat." Crystal had made a couple other videos about this experience, but I wanted to hear the full story, so I contacted her via DM on Instagram. We spoke on Zoom for over an hour. It was an incredible conversation and really emotional. Crystal told me, and she had made a TikTok mentioning this as well, that she tried to take her own life because for 2 years, 3 separate gynecologists dismissed her concerns and told her she just needed to lose weight. The 68-pound cyst was eventually detected and removed. Crystal's surgeon described it as though she was carrying triplets beyond full term. This could have been detected much earlier had her providers administered pelvic exams correctly and pressed on her abdomen. As Crystal said to me, honestly, I didn't even know that was a thing until I talked to my friends and they were like, gynecologists are supposed to press on your outer abdomen. I was like, that never happened to me. A lack of knowledge on what to expect for a pelvic exam is a large-scale systemic issue that has harmful consequences. In November 2020, the University of California system reached a $73 million settlement with more than 5,500 patients of former UCLA gynecologist James Heaps. In February of this year, a separate settlement of $243.6 million was reached with more than 200 people sexually abused by Heaps. In March 2021, USC announced it would pay over $850 million to hundreds of women preyed on by campus gynecologist George Tyndall over nearly 3 decades, the largest sexual abuse settlement ever in higher education, and the LAPD's largest investigation of sexual abuse by a single perpetrator. As of March, only 20 US states have legally banned non-consensual pelvic exams from being performed on anesthetized patients. So there's clearly a knowledge problem regarding the pelvic exam. But how is this a design problem? Why am I talking about it as part of my master's thesis in design writing, research, and criticism? To understand why, let me first walk you through what a pelvic exam is. The pelvic exam is a gynecologic procedure performed by a trained medical provider. This can be an OBGYN, primary care doctor, nurse practitioner, nurse midwife, or physician's assistant. In the US, providers routinely administer pelvic exams as a way to test for abnormalities, cancer, HPV, STIs, and other phenomena that may be causing the patient pain, discomfort, or irregular bleeding, or nothing at all. There are generally 3 steps involved in a pelvic exam. First, an external examination of the vulva and abdomen. Side note, the clitoris is about the size of the palm. Second, the bimanual exam, in which the physician inserts 2 fingers inside the patient, using the other hand to palpate the abdomen and feel for the ovaries. Third, a speculum exam, which allows for the provider to see the cervix. At this point, the provider might also perform a pap smear, swabbing cells from the surface of the cervix to test for cancer and HPV. Sometimes, a physician will do a rectovaginal exam, inserting a finger into both the anus and vagina. Sometimes, just a rectal exam. During all of this, the patient is lying down in the lithotomy position, back flat against the exam table, buttocks teetering just over the edge, feet hoisted into stirrups, legs splayed wide open. Alternative positions can be utilized depending on a patient's needs, like those found in the 1984 publication Table Manners, a guide to the pelvic examination for disabled women and healthcare providers, a 17-page booklet distributed by Planned Parenthood of San Francisco. The pelvic exam prioritizes the role of the physician. The lithotomy position makes it easier for the physician to peer inside, and with the help of the speculum, sometimes plastic, usually a creaky, cold metal instrument shaped like a steampunk duckbill, plus a few squirts of lube, the physician can easily pry open the patient in order to enhance access and visibility. This is a one-sided endeavor, shielded from the patient by way of a thin drape sheet or gown. The complying patient accepts this loss of vision, enduring unfamiliar touch and bearing witness to their own examination through feeling. Not seeing and not knowing is intentionally designed into the pelvic exam itself. In their 1978 report, Dramaturgical Desexualization, The Sociology of the Vaginal Examination, James Henslin and May Biggs analyzed between 12,000 and 14,000 pelvic exams in order to construct a framework for the ideal pelvic exam. They applied a dramaturgical lens, per Goffman's theories on performance, and concluded that the female patient must undergo a process of depersonalization during the physical examination in order to comply with the physician, reduce her seductive nature, and maintain the sanctity of the vagina. The patient loses agency in this process of depersonalization. A loss of agency negates consent. So, how did we get here? Well, the pelvic exam we know today is a product of the 19th century, when gynecology, which evolved from obstetrics, which in turn evolved from midwifery, became a legitimized science, its procedures directly informed by racism and violence. Pelvic exams were first performed as touch only. Laws of propriety dictated what the doctor could do and see with the female body. Tools only became routinely implemented in the late 19th century when male gynecologists assumed total control of women's health care. It is impossible to talk about this history without mentioning J. Marion Sims, the so-called father of modern gynecology, who popularized the pelvic exam as we know today through experiments he conducted on enslaved women in his makeshift backyard hospital in Montgomery, Alabama, between 1845 and 1849. In this 1952 painting by Robert Thom, part of his Great Moments in Medicine series, Sims is depicted as an authoritative figure. He stands with his arms crossed, the speculum he invented clasped in one hand. Kneeling in front of him on the table is a figure of Anarcha. She was 17 the first time Sims operated on her, and had endured nearly 30 operations by the time Sims had perfected his technique. Sims operated on approximately 11 enslaved women in the span of 4 years. Lucy and Betsy, shown here peering behind the curtain, were among those 11. While the residue of this history still remains in gynecology today, cultural perspectives are shifting in a positive direction. This statue of Sims was removed from Central Park in 2018 and transferred to his gravesite in Greenwood Cemetery in Brooklyn. Last fall, the artist Michelle Browder unveiled a monument to the mothers of gynecology in downtown Montgomery, which features statues of Anarcha, Betsy, and Lucy, created out of discarded scraps of metal. A separate sculpture of Anarcha's womb stands behind her, made by Deborah Shedrick. There are also efforts being undertaken to redesign the pelvic exam, designs that expressly seek to address its associated anxieties. Examples include boutique women's clinics, such as TIA, a membership-based service focused on preventive care, and Kind Body, a fertility-focused women's healthcare company. And then there are newer speculum designs, such as Iona and the Nella Newspec from Seek Women's Health, and gown redesigns, like Tia's gown and Embra, a gown designed by Zoe Greenhall for her MFA thesis at Parsons in 2021. While these innovations are important, aesthetics play a major role in regulating mood and comfort level, and I would certainly love to have a speculum that doesn't sound like a carjack in my pussy. I found myself drifting away from material. I didn't feel like the material focus accounted for the decades of abuse inflicted on thousands of patients by gynecologists employed by higher education. And I didn't feel as though places like TIA, who work within the confines of our cost-prohibitive healthcare system, could address the needs of all patients. After speaking with several healthcare providers, midwives, pelvic floor physical therapists, gynecologists, I realized that material design was one part of a broader designed system, one that needed to focus on informed consent. As the American College of Obstetricians and Gynecologists stated in February of last year, informed consent is the practical application of the foundational bioethics principle of respect for autonomy. In other words, informed consent ensures patient autonomy and reduces harm. Pelvic exams need to account for the knowledge gap between patient and provider and be designed to ensure procedures and treatments are effectively communicated. Over spring break, I traveled to New Paltz with my friend Erin to get a pelvic exam from Bertie Condon, my thesis advisor's midwife, at her clinic, River Mountain and Midwives. I had spoken with Bertie a few weeks prior. Like some providers I spoke with, she practices consensual pelvic exams. I did, in fact, record the whole thing on audio, but I will not be playing any of that here. During my exam, I held a mirror to look at myself, while Bertie used a gloved hand to point and name each component of my vulva and vagina, kind of like Velasquez's Rokeby Venus. Bertie conducted a manual exam first. Apparently, my uterus is tipped forward. I felt her move inside me. Do you feel that? She asked. I'm feeling your uterus. And yep, I feel the right ovary. The whole left side is gone. I never knew what that feeling was. Now I had a name for it. The speculum was warm, just like the room. Bertie inserted slowly and began cranking it open. My body became tense, my muscles constricted. But instead of telling me to just relax, she paused, told me to take my time, and let her know when I felt ready to continue, for us to continue. I'd like to end with a quote that I found myself returning to again and again throughout this past year, from Audre Lorde's 1980 book, The Cancer Journals. In becoming forcibly and essentially aware of my mortality and of what I wished and wanted for my life, however short it might be, priorities and omissions became strongly etched in a merciless light, and what I most regretted were my silences. Thank you.